Okay, thank you everyone for joining us today for the DARIA series, the seminar series that we run in partnership through Local Health District St. Vincent's Health Australia and NCCRED. Today we are joined by the chair of the DARIA sessions. That's Dr. Chris Tremonti, who is a staff specialist at St. Vincent's, and he is also undertaking his PhD studies at Sydney Uni. He generally chairs this series, so I will introduce him today. He will be presenting on dexmedetomadine in delirium associated with alcohol withdrawal. So welcome everyone, and please feel free to leave any questions or comments in the chat box or the question box. There's a Q&A box or a chat. Either one will work, and we will be checking them throughout. And also any feedback on the presentations at the end would be most appreciated. And if you want to share the series with your colleagues and your peers, we welcome attendees, and you can forward on that Zoom link at any time. So without any further, introducing Chris.
Thanks, Krista. Yes, nice to be the other way around for a change. So thank you all for coming. I'm going to be talking about dexmedetomadine. The title is a very poor attempt at a pun on Precedex, which is the brand name. So as mentioned, I'm going to be calling it by its proper scientific name, dexmedetomadine, even though everybody calls it. It's one of these drugs that's fallen into the trap of everybody calling it by its brand name, and it grinds my gears no ends. The reason this has become relevant, we'll talk about in a moment, but it has gained some recent relevancy. But we'll also talk about the pharmacology of it, its sedation profile, why it's a hard thing to study anyway, its role in alcohol withdrawal delirium. I will look a little bit at alcohol withdrawal, separate to alcohol withdrawal delirium, so we should separate out those two things. And just a very, very, very brief look at some of the other withdrawal syndromes that exist. So just the background to the to dexmedetomadine. Well, firstly, I should tell you a little bit about the medication. So it's an alpha-2 adrenal receptor agonist. It was developed in the 60s. Sorry, it wasn't developed. The class of medication that it's from was developed in the 60s. The first one that was developed was clonidine, which I'm sure you're all familiar with, which has been used somewhat for off-label for symptoms of withdrawal for some time now. They then found that these medications at an adequate dose are sedating and depress cardiovascular function. And so then clonidine eventually did get approved for use as an antihypertensive, but was used off-label for alcohol withdrawal and pain management. And you do still see that quite a bit in intensive care and so forth when patients have got pain or hypertensive secondary to pain. Often clonidine will be the go-to. Then veterinarians then started using this class of medications when they were doing procedures on animals. Makes sense. It's reasonably, it's reasonably sedating without suppressing respiratory systems. So from that point of view, it's quite good for if you're trying to sedate an animal. And then eventually dexmedetomadine was approved by the FDA, which is the American Food and Drug Administration, for human use in 1999. As a short-term sedative and analgesic, and that I should point out that remains even to today. So the short-term aspect, it is technically only meant to be used for 24 hours, and we'll talk a little bit about that in a moment as well, because there's concern about rebound hypertension, and I've certainly have seen cases of people coming off clonidine, also in the same class of medications, who do get a rebound hypertension when they stop using it, but that hasn't really been demonstrated so well with dexmedetomadine. So yeah, like I say, the TGA and US FDA technically say on this, and this is straight out of Australia's TGA, the equivalent for sedation of initially intubated patients during treatment in an intensive care setting should not exceed 24 hours. But as those of you who've worked in the intensive care setting or in others places, it's used much longer than that typically. It's very rare for patients to only get it for 24 hours in my personal experience. And so, but nonetheless, there is some evidence, especially in pediatrics, of tolerance. And then, yes, there can be a withdrawal phenomena, particularly, as I say, with clonidine though. So the reason this has become somewhat pertinent is it has snuck its way into the Australian guidelines for the treatment of alcohol problems. So it basically is given a category B recommendation that dexmedetomadine may be used for delirium tremens, so another term for alcohol withdrawal delirium, not responding to benzodiazepines in the intensive care unit setting. This is not in the New South Wales guidelines, not currently in the St Vincent's guidelines, and I'm currently in the process of writing up the St Vincent's or re-looking at the St Vincent's alcohol withdrawal guidelines, and so it's been an opportunity to look at this, and it's nice to be able to actually look at something in a little bit of depth, look at the literature around it, and once you do that, it's a bit pointless keeping it all to yourself. So it's a nice opportunity to share it all with our wonderful LHDs and NDARC and everybody else. So the pharmacology of alpha-2 agonists, we should talk a little bit about now. So everybody thinks of them as alpha. Everyone calls them alpha blockers. It's wrong. They're alpha agonists, so they actually activate the receptor. And then once the presynaptic receptor, so that top part of the receptor, is activated, that provides negative feedback that stops the release of what the American diagram I've shown here is norepinephrine, but it's noradrenaline in Australia. They call adrenaline epinephrine. For those of you who haven't watched enough American-related television around EDs and so forth, or what they would call an ER. There's me getting it wrong. So yes, these are in they're particularly so it does work centrally. So by that I mean it's in the brain, or it can be in the spinal cord as well, but in this case it's in the brain, working on the locus coeruleus, and so yes, activates these receptors, and then that leads to loss of noradrenaline, lowering blood pressure, lowering heart rate, and then lowering of sympathetic activity, and so also sedation that comes along with that. So sympathetic being typically your flight or flight response, and so loss of that. So so basically you can almost think of it as, when I'm explaining the clonidine to patients, I usually use those sort of terms. This is a bit like an adrenaline blocker. It's a bit like, it does give you that sort of calming effect, so to speak. So just to look at this at a system-wide level, as I say, there's reduced, it causes all sorts of effects, not just on the brain, but also on the pituitary gland, so less cortisol, and so again, leading to this less adrenalized system. And so we get sedation, low blood pressure, low heart rate, but interestingly, no respiratory depression. So as opposed to a lot of the other sedative medications that we work with, like opioids in particular, there's no effect on respiratory depression. So it's used quite a lot in intensive cares these days, not just in the drug and alcohol setting, but to try and spare intubation, because if you can sedate people a little bit and keep them calm with this, then it's a way that you might avoid having to intubate them. So patients typically get loaded. If they get loaded and they get any of these symptoms, they kind of dial it back a bit. Sort of older patients or those with liver problems may need a smaller dose or skip the loading altogether. And as mentioned, because of these issues around the heart rate and blood pressure, they need continuous ECG monitoring. And of course, we don't use it in patients where they've had heart block or any issues like that. I appreciate our job as clinicians is to treat patients, but I do also feel that we do have an obligation to use treatments that, we do have a limited resource pool, and so we shouldn't be using things that are outrageously expensive. Now, dexmedetomadine is twice the price of propofol, and it's much more expensive than IV intravenous infusions of some common benzodiazepines. So these are all things that should be, factored in to the decision-making process, particularly if there's a questionable benefit. So it's used now, as I've kind of hinted at, it's used, it's my dad and I used to watch a lot of cricket together when I was little, and we used to always joke that when the ad for the Sellies All Clear came on, you know, you could use it to do anything. The Sellies All Clear could even put in a tennis court and paint your house for you. And nowadays it feels a bit the same with dexmedetomadine. It's pretty common that when you're in intensive care, you know, quite a number of patients will be on there for either sedation or analgesia or withdrawal management or delirium, or whatever else. So it's quite out there. Just a reminder, we won't deep dive into alcohol withdrawal delirium today and its management, but it's and this is again pitched from straight from the same guidelines that I was showing earlier. But basically, yes, as we know, you know, sometimes called delirium's tremens, and usually it's a patient has a disordered sensorium, so they're confused, agitated, they might be aggressive, not know where they are. And typically it is a diagnosis of exclusion because there's no real clinical biomarkers of that tell us, well, you know, we can't just do a blood test and this is elevated, so therefore it's alcohol withdrawal delirium. You know, you want to make sure you're not missing another diagnosis and that there is a good history of alcohol use disorder, and then you can, you know, look at that as your diagnosis. But it is tricky. It can come on, it can be a bit delayed in its onset, so it can sort of come on after a few days. But I guess the good thing is typically if we treat well in this, you know, where it says seizures here in this early part, if we treat well at the start, it can, you know, the rates of it are quite low, which is good. And typically, you know, unfortunately, the horse is often bolted when it comes to seeing patients in delirium tremens and trying to get them back, so to speak, to a you know, a non-disordered, an ordered sensorium. Can be extremely tricky. So a lot of the management, unfortunately, is tailored more at protection of the patient's safety and the safety of those around them. So this leads to a lot of challenges in the literature when evaluating something like this, especially for, you know, for a condition like alcohol withdrawal delirium. So as mentioned, you know, you're going to have patients that may be unconscious or aggressive, not know what's going on, have an unclear history, so very heterogeneous patient group. There's no biomarker to confirm alcohol withdrawal delirium. You know, and even in DIMES we do diagnose it. We still are cognizant of other potential diagnoses. And of course, delirium in the intensive care is multifactorial. There's a lot of other things that can be going on. So they might be post-operative, which is a very common cause. ICU itself loses itself because of just the nature of the dark environment that patients are in without a lot of windows. They may have concomitant substances. They could have COVID, for, you know, or other infections. Of course, as mentioned, dexmedetomidine is used for a variety of purposes. Again, so that makes it very hard to, when you're doing retrospective studies, it can make, yeah, that's obviously a big challenge. If you're doing prospective studies, then obviously you've got to try and limit out these other reasons for use as much as possible. A lot of the studies also have various primary outcomes. So some are, you know, looking at, oh, we spare the amount of benzos. Some it's, oh, amount of time it took to get them extubated. As mentioned, there's lots of retrospective studies, and you know, a lot of them are done by intensivists. They're not drug and alcohol clinicians that are doing these studies. Not to say they're wrong, but you know, it's just a different thought process often when it comes to research, when it's done in different clinical spheres. And of course, the goals of treatment may be the safety of others rather than anything else. So I'm not going to look at literature on the general use. I'm not going to look at literature on unspecified delirium. I'm not going to look on dexmedetomidine for delirium prevention, because these are things that are extensively studied in the literature, and there's lots and lots of things on them, but we've got limited time and an audience that's probably not interested in that, so we're going to keep it simple, stupid. So alcohol withdrawal delirium. So probably the main systematic review that has probably perhaps generated this finding or this new addition to the guidelines is this one. So this basically was looking at patients admitted for alcohol withdrawal. It was looking in delirium in alcohol withdrawal, And it could be patients that were coming in, saying I need a detox, or it could be patients where they had it as a complication. And again, adding another layer of complexity and difference to the patient group that we've got. So they weeded through a number of studies and basically got it down to 4, which is pretty disappointing now. And the study also mentioned that they had 55 patients. I count much higher than that because I've managed to pick out the studies that they got. And as you can see there, 16 plus 20 plus 10 plus 18 doesn't equal 55, but nonetheless. And they were typically in their late 40s. They use a variety of things to look at outcomes. So I'm assuming most people are familiar with a CWAR. They also use a Ramsey scale. They use the Richmond Agitation Sedation Score, which is commonly used in intensive cares, where it's basically just, I'm a 0 right now, but if I became a little bit hyper, I'd be a +1, and then +2, +3. And then there's sort of the same the other way. If I started to nod off a little bit, I'd be a -1, etc. And then there's the confusion assessment method for intensive care. So their conclusion from all of this, and I'll go through in a little bit more detail, was that in all 4 studies, there was an improvement in mean tool scores after dexmedetomadine was added to standard benzodiazepine-based therapy. So this was their meta-analysis, so done on the forest plot, and so basically for those, I appreciate we've got a wide variety of people participating today from, some people are very research heavy, and for them, I'm telling you to suck eggs, but for those people who are more clinically focused, you might not look at these things often. And so basically this is plotting out, on this one, they're using CWAR. So basically, they're trying to plot out each of the different studies and then give an overall score as to how much of a difference the CWAR to CWAR it made. And typically, they give the line. So you've got a vertical line. That's the sort of the average that they're guessing, and then the vertical line is the horizontal line, I should say, is the confidence interval. So in theory, if that confidence interval crosses this line here, we can't really draw any conclusions from that, but they've averaged them all together and they've come up with this line here, and it doesn't cross 0. So we can say that it has made a difference. The other important thing, though, to look at whenever you're looking at a study is the clinical difference all that important? So in this, it was an improvement of a CWAR of 5. So for some context, a 10 sort of considered, looking at scores of 10 to 20, we'd start to call that sort of moderate withdrawal. Over 20, we'd call that severe withdrawal. So, a difference of 5 could potentially push somebody back down 1 from, say, a severe of a 22 down to a more moderate of 17, but it's not a huge difference. It's not massive. And the RAS of 1.5 to 0.3, which is 0.3, which is actually not too bad. And as I say, I'm a 0 right now, so that's perhaps a good thing. At the same time, a RAS of 1.5 does make me wonder if they were choosing patients that were that hyper to begin with. Just to focus on a little bit on the side effects, because that is important. So in the studies, there were patients who had either bradycardia or hypotension, and for various reasons, had various treatments for that, but it didn't sound like anybody had anything significant beyond that. And when I say sick sinus syndrome, so they're going fast and slow, and then fast and then slow, and there's typically more antecedent causes to that than just the medication. So this led to their final statement that the use of dexmedetomadine as an adjuvant to benzodiazepine-based therapy decreased delirium more effectively than benzodiazepine-based therapy alone in adult ICU patients experience alcohol withdrawal delirium, as evidenced by a decrease in CWAR and RAS. And again, I should probably have pointed this out earlier, and one of the other challenges is that different places have different protocols around how they even manage alcohol withdrawal and alcohol withdrawal delirium to begin with. So some will use benzodiazepines, but choices often, almost all of them will use benzodiazepines, but their choice of dose, route, type, some places use lorazepam versus diazepam versus midazolam versus all these things. So there's lots and lots of things to factor in there. So obviously a lot of limits here. So the small numbers, it's a questionable clinical change, and it's largely retrospective. And so really with retrospective reviews like this, you can draw an association, but you can't necessarily say that there's a causation there. So it is something of a challenge. So just to dig a little deeper into a couple of the studies, just to give a bit of an idea of what those studies are like. And look, they're not bad. This was a Finnish study, Tolonen. This was the one that I think that didn't use CWAS, so was excluded from the forest plot. But this was a single arm, basically. This was the only one that was prospective. Sorry, the other three were retrospective. And so this was actually, they said, we wanted to basically do a safety study to see whether or not this was dangerous or anything like that. They all got benzos, some had haloperidol, and they were all given the treatment. So it wasn't like they were comparing them to anyone. Patients, none of them were intubated. They resolved, their delirium resolved in about 4 days, which is not bad. They used about 260 milligrams of diazepam equivalent, which again is not horrific. They were in ICU for about a week. Again, I would say that that's consistent with a lot of our experiences. And there was a death from pancreatitis, which wasn't at all related to the medication. So they were basically saying that this was, supported the use, but they obviously needed a randomized control study to further evaluate it. Now, this one was odd, and I have included it because the study that looked like it got the meta-analysis looked like it got an update. So perhaps some people who are better at literature studies and so forth, some of the researchers online here can comment on this. But basically, this study was published under the name of Foster when it was in the or under the author of Foster when it was included in this meta-analysis. But then I see it's been updated to Vanderweeder subsequently. So somebody smarter than me, or more in the know, or more cynical, or more anything, can tell me what on earth that means. Nonetheless, their goal was to assess the impact of dexmedetomadine administration on benzodiazepine requirements in the ICU. And again, this was retrospective. And this was using some early dex versus no early dex, and they matched basically. So they tried to find people who'd been in hospital previously, who had been similarly matched for things like age, gender, and those sorts of things, and who hadn't received dexmedetomidine. But yes, as I say, I've made the point there that it was also in a different journal. So I don't know whether that journal decided to pull it and then they've published it in a different journal. I don't know. So somebody smarter than me can tell me why that is so. So basically they had a trigger of patients who'd received 8 milligrams of lorazepam as per their sort of protocol. So as equivalent, so that's probably about 60 milligrams of diazepam, so pretty equivalent to what we do here. And there's a variety of exclusions there. Again, this is something that does come up as well in the literature that makes it a challenge, is that sometimes there are exclusions paced and you go, well, isn't that the exact sort of person that we want to sort of see what happened? So for example, death in 72 hours was an exclusion criteria. I'm not saying it was the dex, but I don't see why you would exclude them, and you can just look at what the reasons were for their dying. Nonetheless, the match group was so basically it was based on, they used the lorazepam, and what they did that was weird in this was they used like an inflection point. So this was where they compared, because the people on dexmedetomadine, you can say, well, they started using dexmedetomadine here. What they did with this study was they went, well, this is where their benzo requirements went less, so that's the equivalent of where they started using dexmedetomadine. So it's unusual, but I guess what they're trying to say is the point where they got better, or the point where they perhaps felt they'd had enough on board, and so then the requirements became less, and so then they looked at how much benzo use they were having. Should also point out, benzo use is in of itself, because of these scales that we use, patients may receive various different amounts for different reasons. The two nurses on it, the same patient the same clinical features and yet may well have graded them differently on the CWAS and whatever else. And that's not to criticize nurses, that's to criticize standardized scales. So yeah, and then they looked at a whole bunch of secondary outcomes. I hope that makes sense, by the way. This inflection point thing, this took me a good 15 minutes of looking at the paper to work out what on earth they were doing here. Anyway, so they looked at the 12-hour, the difference in benzo use 12 hours post this inflection point and the difference between that in the 12 hours before the inflection point. And yes, basically the amount of use had dropped by 20 milligrams of. Now I'm going to have to admit here, I think they said I think they were using lorazepam, so I will assume this is in lorazepam. Yes, because it's 12 hours. Yes. So no, it's not. It's yeah. So looking at it, so basically what I'm saying here is that in the 12 hours afterwards in the Dex group, they used about 140 milligrams of diazepam less than the 12 hours before they started using it. In the inflection point group, the people who didn't get it, they used about 60 milligrams less of diazepam equivalent in the 12 hours after the inflection point there. So I guess what they're trying to say here is that there was quite a big benzo sparing role in using dexmedetomadine. Now, again, that there's, you know, read into these what you will, because as I say, places may have different protocols, you know, people may have different different clinical assessments, you know, and benzo use it's a very it's an very indirect marker of how the patient is doing. So, you know, take all these things with a grain of salt. Nonetheless, you know, across the whole, their outcomes were pretty good. You know, so you know, patients seemed to do, you know, better when they're in, when they had dexmedetomadine on the whole. I won't go through each and every one of these outcomes. So yeah, so basically that was what they established. So and as I've kind of pointed out here, you know, is a query, you know, did starting the dex prompt the reduction in the benzodiazepine use? So what I'm trying to get at there is the thought process of, well, we've put the dexmedetomadine on, put the benzos away, boys and girls, we don't need them anymore. So, you know, it may well be that that's really what's going on, rather than, you know, anybody actually not using less benzodiazepines. And as I've said, it's an artificial inflection point, so it is an unusual way of doing it. I don't actually dislike it that much, the more I kind of reflect on it. Just to pivot slightly, I will just talk a little bit about alcohol withdrawal. So this was and I'm doing this because I think some of these studies were interesting to look at. So I think it's better to look at some of the better studies. This was a Ukrainian study which was prospective and actually placebo controlled. So that's always nice. And basically all of them got diaz, and then they added in some dexmedetomadine to see whether or not, again, you know, 24-hour benzo use, this surrogate marker that they're using quite regularly, but they did actually look at a wide variety of things. They took anybody that went into intensive care with alcohol withdrawal syndrome, so whether or not they were there because of the withdrawal or because of something else. There wasn't any mention of a severity cutoff either, which is but having said that, you know, CWAS 25, 26, that's pretty good. So, you know, it was just a caveat that I had noted. So yes, they could be there for, and there was a variety of other, you know, exclusion things, and which always frustrate the bejesus out of me. You know, severe comorbidities. You know, if they'd had a heart attack, I mean, I don't think that should. I guess with dexmedetomadine, it is a concern, but you know, even still, sometimes I, you know, do wonder. So yeah, this was their outcomes. And basically the groups had, they did use a bit less diaz. It wasn't huge, and spend a bit more time at their target sedation, which was also good. So yeah, and given its prospective nature, you can sort of add all these together in a way to kind of say, well, it looks like it's providing some benefit. They didn't use it for long, which is pleasing as well. And the patients, whilst okay, I'm not a big, I don't believe we should worship at the temple of p-values. So there was a median length of ICU stay of 50 hours for 70 hours, which I think, a 24-hour reduction in intensive care is nothing to sneeze at. We need patients to get better and get out of hospital, and ICUs are very expensive. So even though there's a P of 0.059, I'm happy to let that slide. And they were hospitalized for reduced time as well. Only one person in the DEX group went into alcohol withdrawal with delirium, and 4 in the benzo group. But they excluded these patients. So go figure on that one. Go figure. Just mindful of time. We've got a little bit of time. But do feel free to interject with questions or anything, or if there's a study you want to talk a little bit more on, or anything, I'm happy to pause. So this was another one that was placebo controlled. So again, you can see why I'm cherry picking the good ones, or the better ones, I should say. Again, small numbers, 24 patients with a CWAR of over 15, despite getting very high doses of lorazepam. That's getting up, that's over 100 milligrams of diaz equivalent. And so basically dex v placebo. And the difference in 24 hours after the study drug was greater in the dexmedetomadine compared with the placebo group. So that was rather, sorry. So as in, again, they've done the difference in the amount they needed. I think I've worded that rather badly. So the requirements went down. So basically it was an improvement in the 24 hours after they gave the dexmedetomadine. Interestingly though, and I think this might play into what I was talking a little bit about before, was that over the 7 days, there wasn't that much of a difference. So again, perhaps there is a little bit of, well, we've put the dex on, we can put the benzos away, because the dex is going to do its thing. Don't worry about the benzos. And look, it's use of benzos once in established alcohol withdrawal delirium is a vexed question in and of itself, and certainly there's issues around benzos because they can cause delirium in and of themselves. So there's all sorts of challenges there. So it is tough to know what is right to do. But again, I think this kind of feeds into that phenomenon that I'm talking about. Don't ask me why I've specifically gone out to include FRACP. I can't remember. There aren't that many studies out there. I thought I'd sort of cherry picked the best ones. Perhaps I haven't. So this was a retrospective case series of 33 adults, and then, as I say, again, a bit of a reduction in benzo use. Seems to be a bit of a common theme here. Hopefully not too many more of them. So then this, again, retrospective. So just giving you an idea of using dex as support, and versus benzos being escalated. And this was basically a bit different in the sense that they knew they were going to be giving more benzos. So to see whether or not they needed to intubate or any sort of severe complications, and then a variety of other things. And they then put all of that together into like a composite N score. And really there wasn't really much difference between the two. So there wasn't really much difference in terms of respiratory distress or seizure or anything. And I think what they've really set themselves up to fail with this one, because those things are not common. So you need sort of big patient numbers to kind of draw any meaningful difference out of the data. So where they have got a difference is the common things in bradycardia and hypotension, because we know that happens very commonly with dexmedetomidine. So I really don't think we can draw a lot out of that. Yeah, similarly, I think if from memory, this study was actually focusing quite a lot on this bottom line here. So basically saying it's costing us a lot more money. So I think they were sort of trying to make this point that it's not really doing a lot, and say, it's costing a lot of money to do so. So, is it worthwhile? I think this is the last one about alcohol withdrawal, so bear with me. And this was a retrospective study of 77 admitted to the intensive care unit, and again, looking at difference in lorazepam equivalents. And basically, I think the reason I included this particular study was just to note the sheer amount of use. So you can see there that use of dexmedetomidine has just gone through the roof. So whether or not it's in guidelines or not, people are doing it. Often it's started well before we're consulted. We don't know the patient. A lot of our patients don't get to the point of alcohol withdrawal delirium because we're managing it, we're on top of it. It's often patients who are admitted for other reasons that end up on in intensive care with delirium tremens, or complications of alcohol withdrawal. And they're not under us, they're under the surgeons, they're under the neurologists, the cardiologists, whoever. And ultimately, and this is another issue, not I say issue, but just another consideration, is that intensive cares are often a closed unit, so they will dictate what medications are used and will take advice from teams, but ultimately retain the control, so to speak, to the point where other clinicians can't prescribe medications and so forth. I actually think that that's a totally fine situation because of the intensive care, but of course, then sometimes it does lead to situations where you're not sure about the use of certain medications. But nonetheless, look, this one said there was a bit of an improvement in CWAS, no difference in benzos, and the dexmedetomidine had also significantly longer hospitalizations. So just this is case report stuff. So this is we sort of started at the wrong end of the research pyramid. We started with the systematic review and meta-analysis. We're going right back now to some case studies. So it's interesting to look at people using it in various things. So this was some people using dexmedetomidine for baclofen withdrawal. I haven't seen really much baclofen withdrawal most of the time. I'm not saying this is what always happens, but often baclofen withdrawal is actually often associated with people who have it intrathecally because of treatment for spasticity or whatever else, from a complication from spinal cord injury or so forth. And so it's unusual to so we just don't see a lot of it. But nonetheless, people have tried it for that. And this was a case report of cocaine, and they had dexmedetomidine for 36 hours because they were hypertensive and tachycardic after coming off cocaine, which is a bit unusual because cocaine itself is usually cardiac stimulating. So it's a bit of an unusual one. And then there was this one, opioid and benzos. So it was iatrogenic opioid and benzo tolerance, and they had 7 days of dexmedetomidine, but I don't really know what happened in the long term. And as we know, patients often relapse quickly after coming off after coming off opioids without proper opioid treatment therapy. And again, a patient who'd had it for heroin withdrawal, again, why we wouldn't just use bupromethadone? Beyond me. GHB, so obviously there's a lot of interest in GHB withdrawal as well at the moment. Whether or not this is an adjunct to treatment of that. And good old phenibut as well. But this was actually they found quite a number of cases. We don't get a lot of phenibut here. Do see it, but basically patients were chronically using phenibut, and they abruptly stopped, and they had severe hypertension and so forth as well. So it did make sense as an agent to treat that, because you're kind of covering for two things at the same time. So I guess, there's some pros and cons to weigh up. We're in by the time, often these patients are in the intensive care, so therefore it's relatively safe. And we are limited in what other treatments we have to offer outside of atypical antipsychotics and benzodiazepines. There may be a role to spare a bit of benzos, and that may also help people feel a bit better that they don't need to give benzos. And it's used commonly, so it's not like we're asking the intensivists to do anything they're not already doing. The cons are that it's a heterogeneous group of patients, and often the definition of what they've got is unclear. Even I've caught myself saying delirium tremens a couple of times during this talk. We probably should use alcohol withdrawal delirium or delirium from alcohol withdrawal. Keeping the terminology consistent will lead to us having better understandings and being able to accurately frame what it is we're managing. There's limited numbers. There's potentially negligible differences sometimes in some of the studies when you dig a little bit deeper. There is, of course, a cost to it, but I guess say in the pros that potential pro is reduced hospital admission, which itself is a money saver. And then different endpoints and clinical creep. So for those of you who aren't familiar with the term clinical creep, a clinical creep is where there's an indication for using a particular medication for a particular thing. Pregabalin's a great example. It's there's evidence for it in chronic in neuropathic pain, secondary to a couple of conditions, but then it gets it's slowly crept into the management of pain in general. So, and again, similarly, dexmedetomadine probably falls into that category. It's being used for sedation or management and so forth. Tremonti state, well, what did I write? I actually, I prepared this last week, and sort of you have time to reflect on it, and you do wonder if it's worth it. I think, have I got it right? Patients with severe alcohol withdrawal in spite of high-dose benzodiazepines that manifest as cardiovascular and delirium, and there's no clear role in other withdrawal syndromes, no clear role, beware. Okay, all right. If it's a bit of a cop-out. Look, if I think I would probably say it's, I don't know whether it's guideline ready yet, but I think it's probably is okay. Something that we can recommend, but obviously I think it is used very liberally, and everybody does need to be wary of also the side effects. Particularly it is hepatically cleared, hello liver disease, looking for cardio, issues of cardiomyopathy and so forth in patients who've got alcohol dependence. Whether or not it's be used preemptively, I doubt that's very necessary. Whether or not it's used in other withdrawal syndromes, probably not at this stage, but you never know. So we've got 10-15 minutes. Perhaps I should let Krista do her job as chair.
Thank you. Thanks, everyone. Thanks, Chris. That was a great talk.
My
I
pleasure.
do want to just, before I start with a question that I had, I wanted to
Sure.
particularly put out if there are any participants on the call from West, Far West, or Southern who would like to share what's clinically standard in their contexts and what their experience is in other LHDs, just recognizing that at St. Vincent sometimes things get done more routinely or differently than some of our other partners. So I'm just putting that call out if there's anyone on this seminar that wants to share that experience with us.
Yeah, I think that's thanks, Krista. I think that's a really important point to emphasize. Yeah, absolutely.
Great. So while we're waiting for that to come up, I did have a couple of questions. I guess the first thing that really struck me is just the you clearly did a deep dive into the literature, and I felt increasingly disappointed with what you were finding.
I did go the wrong way around. I did tell you that, didn't I?
You did. But even when we started, I thought, gosh, if you can't get the sample size ready, if you can't get the sample size accurate on the data that you're systematically
Yeah.
reviewing, I start to wonder what other holes or what other mistakes, and it starts to freak me out a little bit.
Well, it could have been me, and I wonder if they sort of, I don't know. I couldn't pick out why that number was different. It bothered me, and I couldn't get to the bottom of why that was so. But anyway, sorry, go
And
on.
sometimes it's there, but it just they don't make it easy for the reader necessarily, because
Yeah, it's in the supplementary.
it's also an
Yeah.
issue with writing, right? We think we're writing something, but we have this background knowledge that we think everybody has. But to keep the reader up with us, we have to be really clear. And so I guess one of my thoughts as you were talking was perhaps either as part of this seminar series or perhaps separate to this, maybe we should do maybe we should have a talk about how to, critically appraise a publication and what to look for quality, and how to sometimes get to the bottom of some of those really tricky papers.
Yep.
But that's an aside in in sort of taking
I think you would
from what you were chatting.
You would tear, I think, a lot of these to shreds, Krista. I think you really would. Like, I mean,
I'm sure people would tear my work to shreds too. And I think a lot of it is what's implicitly known when you're writing, and what you assume the readers keeping caught up with. So I think that it is a challenging body of literature. And I also just wanted to reflect. So in that systematic review, they had you showed the forest plot, but some of the studies included were retrospective case series. Did they always have a comparison group? So did they always look at?
Yeah, they did.
They did.
They usually had a matched group that they based. I can't remember. So we talked about Foster, which was the sort of renamed study. Daly and Ray, I probably should have talked a little bit more about them. I apologize that they seem to be lost in the ether. I think they had matched by. I'd have to double check. I couldn't tell you, but I'm pretty sure they had sort of like a matched cohort.
Okay, and probably it sounds like for the most part benzos, and so I guess I know that it was out of scope for your talk, but I was thinking, and I couldn't help but think as I was going through your slides, just linking back to some of the sort of preventative and prophylaxis. So if you're thinking particularly about someone who's coming in for surgery, or maybe somebody's had a fall at home and it's an unintended or unanticipated surgery, and it becomes clear that this person probably has a high risk of having some delirium when they wake up. Is this useful in that context as well? And do you have anything to add? I know that it was out of scope, and I think you mentioned that it was out of scope for this talk.
No, that's fine. Look, I've I'm not the world's foremost expert. I've been doing this long enough now, though, that I don't think I've ever seen an adequately treated patient go into alcohol withdrawal delirium. Like, I mean, I'm happy for someone else to jump on the line and say they've had a patient with this, and and we gave them this, and even in spite of that, they then they went completely nuts. Almost always it's the horses bolted. From my experience, I'm happy for somebody to get onto the chat and say, Dr. Tremonti, you are wrong. And then I'll say, you're wrong, call me Chris. But so I don't, and that's why I don't know if it has a role as like a prophylactic thing, unless there was some reason they couldn't get diazepam in. I mean, diazepam's available IV as well. So you even if you're having an operation and you've got all these high risk things, you can find a way to get it in. There's other forms of lorazepam and midazolam and
really
so forth.
First line and prophylactic.
Yeah. So I think I don't think there's a role for that. No.
Okay.
Personally, happy to be, happy for other people to prove me, to challenge that.
Great. And we do have a question come through from Craig. Just I don't know if it's a question or more of a comment, just about, reflecting on how much of a say someone who's not an intensivist in many of these presentations actually gets determine?
Look, sorry, the other thing I should have pointed out was the other reason I thought this was a bit pertinent was one of the LHDs did call me. There was actually two in the space of about a month from two different LHDs, both in this forum, but it wasn't, I don't think the people who called me are definitely not in this forum. And one of them was definitely an intensivist. So they were actually ringing, seeking our advice through DASAS about what to use for this. So I think it's you're right. We often don't because they are closed units, and they will often they'll go with what they're comfortable with. They may well just intubate somebody if they feel like they want to take control of an aggressive patient. And yeah, so that is a challenge. So and as I say, like most of the time, it's not patients that we're managing; it's patients that other teams are managing. So it's tricky.
And Craig mentions an experience seeing that in GHB withdrawal as well,
Okay.
which is interesting.
Okay. I haven't.
Doesn't sound like, from what Craig said, doesn't sound like it had much effect.
I don't. I'm just trying to think that I probably have seen it at some stage for some of these withdrawal syndromes, but I guess it's a case of I haven't diagnosed the withdrawal syndrome and they happen to be on it and they happen to use a bit of this or that or t'other. So it's probably my best experience with it, like in terms of the other, that's about as good as it gets.
And I guess the best clinical practice is to treat the delirium in front of you a priori and acknowledge that it's a delirium precipitated by any cause. And so you're
obviously
treating
the cause is the main thing.
Yeah.
But look, sometimes people will see that it's a patient with various substance use issues and then just bang, dexmedetomadine. So that's a challenge as well. So yeah.
Interesting. And maybe we should have invited some ICU colleagues today.
So someone once wanted me to present on this topic to some intensivists, and I thought I said there's no way you're throwing me to the wolves on that one. Like, not a chance. Like it would look, no, because it's certainly not done with a tone of we know better or anything like that. It is hard, and when there's established practices and as I say, it's different mindsets of how you approach patients, and
it's very contextually different as an old critical care RN. Well, thank you so much for your chat today. We don't have any more questions, so we might let out just a few minutes early.
Yeah, I think so.
Thanks everyone for coming along, and I just want to remind everybody that this is open invitation and you can forward those invites along to colleagues and peers, and we welcome you to do so. We will be moving forward with a different Zoom setup coming up, and I think we will be doing a little bit more comms around advertising a bit more broadly. So hoping that we can continue to see people come through. And I'm just noticing somebody's popped something in the chat. I think Nadine's just shared a paper if you wanted to open that file. And we will follow up again next week. So thank you everybody for your time this afternoon, and look forward to seeing you.
Thanks everyone. Thanks Krista. Thanks Nadine.
All right.